Dr. Anthony Staines. He's an authority in patient safety, and I consider myself to be a student of patient safety. So it's a real proud privilege for me to actually introduce him. He is the Patient Safety Program Director at the Federation des Hospital Borders in Switzerland. He has a vast experience. I've seen his the profile, and he has been a CEO to various hospitals, and so he is a vast experience as an administrator in healthcare. He's not only an administrator, he's also a author in various, and has published various articles. In fact, he is currently the deputy editor of the International Journal for Quality in Healthcare. And along with Charles Vincent, he has recently co-authored Swiss National Report on Quality and Safety in Healthcare. Who better than him to tell us about a certain aspect of patient safety? From my personal point of view, we did safety culture assessment in our institute, and obviously we wanted to understand the baseline of safety culture that is there in prevalent. I'm sure most of you also would have been part of such an assessment in your respective institute. The next question comes is what next? How to improve upon that? I think I'm sure this is the topic that Dr. Staines would be touching about. And without any further delay, I'll request Dr. Anthony sir to proceed with your session.
Well, thank you very much, Dr. Shetty, for this very kind introduction. And I'm delighted to be invited to the session. So I will be presenting the contribution of the TeamSTEPPS methodology to improve patient safety. And I want to start with a word on why our hospital federation in Switzerland has chosen TeamSTEPPS. The idea came from a group, a coordinating group for the implementation of the WHO surgical safety checklist a few years ago. After about 5 years of implementing the WHO checklist, we had a discussion within the group of coordinators for the one coordinator for each of the hospitals of the hospital federation. And the feedback was to say, well, we believe we have improved in ticking boxes. And what we've not really improved on is actual teamwork. We are not sure that when we tick a box, there has really been teamwork for patient safety. Like when you identify the patient, it's 4 or 5 different people checking different aspects, like the wristband, like having welcomed the patient at the OR and having had a discussion with the patient, like the patient record, etc. And it's the cross-check of all these different information that produces the teamwork that allows you to tick the box. And that was not really happening. And so the coordinators asked me, as the chair of that group, to find a crew resource management method to improve patient safety and improve teamwork. And that's how we came about selecting the method that is TeamSTEPPS. So TeamSTEPPS stands for Team Strategies and Tools to Enhance Performance and Patient Safety. What you have on your screen at the moment is the model of TeamSTEPPS, and you can see a circle which represents the patient care team. So there is a chapter of TeamSTEPPS dealing with who is on the team, what are the skills that we need on the team, and how is the team organized. And then there are 4 transferable skills, which are communication within the team, leadership, clinical leadership, situation monitoring, understanding where we stand in terms of risks and where we stand in terms of delivering safety, and mutual support. And if the team is well organized and these 4 skills are well implemented, then TeamSTEPPS says, so you can now see the model that I was talking about, the circle representing the care team, and the 4 different transferable skills, which are communication, leadership, situation monitoring, and mutual support. And TeamSTEPPS says if all this is well implemented, then it produces different results in terms of improved knowledge, like gaining a shared mental model within the team, improved attitudes, improved in terms of compatibility with patient safety, which are mutual trust and team orientation, and improved performance in terms of adaptability within the team, accuracy, productivity, efficiency, and safety. So in the next few slides and in the next 15 minutes I will focus on the patient care team and these 4 different transferable skills. So one slide about the team. TeamSTEPPS insists that in a healthcare environment, it's about a multi-team system. So of course we see and we focus on the core team, which is the patient's environment, which are the people at the bedside, but there are also contingency teams like resuscitation teams, medical emergency teams, there are coordinating teams, support services, and the administration who provides the resources, who fosters the right culture, and the patient who, for TeamSTEPPS, is included in the care team. I'm saying it again because it's so important. The patient is part of the care team. So TeamSTEPPS and the different tools and approaches that I'm talking to you about today are for the core team, but also for all of the different teams in the healthcare organization, and some of the tools apply to the patient as well. So let me move into the first transferable skill, which is communication, and I will provide a few examples of tools and approaches that TeamSTEPPS is suggesting. I don't have the time to go into all of the tools, but I will provide some examples. The first is called SBAR, and it's a framework for team members to effectively communicate information to one another, particularly in stressful situations and in time constraints in emergency situations. And it encourages the team members to communicate the following information. First, to describe the situation, which is sort of the title. Why am I calling? Why am I communicating with you? What's going on with the patient? The second step is communicating the background. What is the clinical background or context? The assessment, what do I think the problem is? And the recommendation, what would I recommend? So it's a tool for structured communication to not be a victim of different styles which bring confusion in the communication, like there is a style for nursing and a style for physicians, and to have a homogeneous tool for multidisciplinary and multi-professional teamwork. Let me illustrate that with a video.
Hi, Dr. Feldman. Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention. And she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah, well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale, but not uncomfortable. Her coag studies are within the parameters, and her blood gas is normal. All other AM labs are normal. She's not putting out much urine, and it looks cloudy to me. I'm worried about her. I think she needs to be seen. You want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
So let me move on. That was one example of a tool of TeamSTEPPS, SBAR. The second one is a simple one, which you are probably all using already, which is the Callout. The Callout is a strategy used to communicate important information and critical information to all of the teams simultaneously. So it's one member of the team speaking loudly so that everyone can hear and so that everyone gets simultaneously on the same page. Like in the OR, the anesthetist would say, I'm injecting this or that, or the surgeon would say, I'm moving to this step of the intervention, and people can expect the next step. The third tool in the communication chapter is the Checkback. The Checkback is a strategy to promote closed-loop communication. So the sender would initiate a message, the receiver would accept the message and rephrase it, provide feedback confirmation, and the sender would verify through this rephrased version that the message was well received. So for instance, someone in the OR would say, please could you do 10 of ephedrine? And the receiver would rephrase, you have asked me to do 10 milligrams of ephedrine IV. And the sender would say, oh no, IV yes, but not 10 milligrams, 10 milliliters, for instance. And this allows safer communication. Here is a video to illustrate that.
1 gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
So the last tool in the communication chapter of TeamSTEPPS is the handoff. It is the transfer of information during transitions of care, which includes an opportunity to ask questions, clarify, and confirm. And it's also the transfer of the responsibility of the patient or the group of patients. And for that, for the handoffs, handovers, TeamSTEPPS suggests a number of tools. Within these tools, we at Hospital Federation of Vaud have chosen IPASS, which is a structure for handovers. It goes through 5 different steps. I stands for illness severity, where you would say if the patient is stable versus unstable or to be watched closely. In anesthesia, you would use the ASA categories, for instance, to describe illness severity. P stands for patient summary, going through the summary of the events leading to the admission, the ongoing assessment, the plan. A stands for action list. Here you would say what your colleague from the next shift will have to do during the shift, and what is the timeline, who is responsible for what. S stands for situation awareness and contingency planning. Here in contingency planning, you would say, for instance, if this happens, then the physician has asked to be informed immediately and to activate this or that plan, for instance. And also, it's the opportunity to review safety issues. And S stands for synthesis by the receiver. It's the opportunity to ask questions and to rephrase the key actions. Let me move into the second chapter of TeamSTEPPS, which is leading teams. And for that, TeamSTEPPS suggests 3 different tools. The first is briefings, the second are huddles, and the third are debriefings. The briefing is a strategy to share the plan for the patient or for the group of patients. So it would happen typically before the day of care starts on the unit, on the ward, or before labor starts in OB, or before an intervention starts in the OR. So it's an opportunity to form the team, to see who is on the team, to allocate roles and responsibilities, to establish the right climate. Please stand up, speak up if you see that there is a mistake about to happen, things like that. The second tool are Huddles, which is an ad hoc tool, short touch-based meeting to regain situational awareness. You would use it if during the briefing you have decided on different things and the situation is moving ahead differently than what you've planned. So the patient's health is evolving differently, or the work on the unit is evolving differently, and you would discuss critical issues, emerging events, anticipate outcomes, reallocate resources, express concerns. The next tool in leading teams are debriefings, which are opportunities to learn from what has happened during the event, during the day of care, and to see what would we do differently next time, or what was good and what would we definitely have to keep for next time. Did everybody get the information that everyone needed, etc. Here is an example of a debrief.
Great job, everyone. Can we discuss how things went today with Mrs. Keys? What did we do well, and what can we do better next time?
It was helpful for me to be brought in early. That allowed me to use a regional instead of a general anesthesia.
You're right, Brad. Lynn, what did you think?
It was great that Dr. Dean helped put the Foley in place while I did the count with Alicia.
Albert, this is a great example of task assistance. How was our communication today?
Excellent.
Great.
The next chapter of TeamSTEPPS is situation monitoring, which is a process that involves 3 different steps. The first step is an individual skill, which is scanning the environment and gaining an understanding of what the situation is for my current patient, but for other patients on the ward, in the hospital, how are things evolving? Through the information that you've gathered in your scanning the environment, you gain a situational awareness, which is an individual outcome, which is understanding and making sense of what you have gained as information. It's not very useful as long as it's not shared during all of the team, among all of the team, and creating a shared mental model is what is needed, and that's a team outcome. Let me illustrate what would be an absence of shared mental model in an environment different from healthcare. So that was the absence of a shared mental model, and I'm sure you can relate that to your healthcare environment and that you've witnessed a number of events where there was no shared mental model. So TeamSTEPPS suggests a tool which is called STEP to scan the environment and to make sense of the environment and to gain situational awareness and then to be able to share that with others and gain a shared mental representation. So the TeamSTEPPS, the STEP tool goes through the status of the patient, the team members, the environment, and then progress towards the goal. So let me take an example. I'm walking along a corridor in a hospital. I see an open door. In the room, I see a patient. The patient is quite pale, and I'm getting a little bit worried. I look around to see if there are team members looking after that patient, and I can find no one, no colleague, no nurse in the room. So I look at the environment, the patient's environment. There is an IV drip attached to this patient, but the drip is empty. And so what do? I contact my colleague in charge of the patient. I express my worries and I offer my help. That's the use of the STEP tool to gain for situation monitoring and to promote a shared understanding, a shared representation. The last chapter of TeamSTEPPS is mutual support. And in mutual support, TeamSTEPPS promotes task assistance, promotes providing feedback, and promotes exerting assertive and advocacy behaviors when patient safety is threatened. I suppose you are all already using most of number 1 and number 2, so I will focus on number 3 and provide an example in number 3. Advocacy behavior, and the tool promoted by TeamSTEPPS is called CUS. CUS are code words to express a concern when patient safety is at risk in your care environment. So your colleagues will understand that when you say I'm concerned, it's a code word to say we need a timeout, there's something going wrong, and I need your attention. And so you would say, I'm concerned, then you would say, I'm uncomfortable. If concerned is not sufficient, uncomfortable is also a code word. And if it's still insufficient, you would say it's a safety issue, and that's the final code word. So for instance, if you are assisting in an operating room and there's an intervention going on and the surgeon is the boss of your boss, which is a delicate situation, and you see him performing the incision on the other side, on the left, whereas you understood it was on the right, you would say, I'm concerned, I understood that it was on the left, but you're intervening on the right, and if it's not sufficient, if nothing happens, you would say, I'm uncomfortable, I suggest that we take a timeout to examine the situation. And if it's still insufficient, you would say, this is a safety issue. I think we need to stop. So these are code words to manage delicate situations where you have to intervene in the advocacy of patient safety. Let me show you an example.
Dr. Dean, I'm concerned about Ms. Keys. I'm uncomfortable watching these late decelerations, the baby's heart rate's in the 60s. I mean, I just don't think it's safe to continue labor.
And so you can see that here, it's not in a room with the patient present, but when it happens with the patient present, it's particularly important to use code words because you don't necessarily want the patient to get worried and to understand that you are not agreeing with your colleague, that you are disagreeing and advocating for the patient's safety. So using code word can be very helpful.
Dr. D.
The last tool that I want to present in mutual support is a conflict resolution tool called the desk script, which is a script that provides a constructive approach for managing conflict and for conflict resolution, which suggests to depassionate things and makes things more objective by describing the specific situation, by expressing your concerns in terms of, I feel this and that, or not saying you did this and that, by suggesting other alternatives and concluding on what are the consequences if nothing happens. So this was the set of examples of tools that I wanted to present. In summary, TeamSTEPPS identifies barriers to communication and to teamwork in the care unit, and TeamSTEPPS aims for outcomes, improved outcomes, especially patient safety, and to mediate, to remove the barriers. TeamSTEPPS suggests tools that are classified in 4 different categories: communication, leadership, situation monitoring, and mutual support. I want to thank you for your attention. It's been a great pleasure to present TeamSTEPPS and to share the experience. Thank you very much.
Thanks a lot, sir.